So this talk is going to sort of be the pivot between what we talked about and fatigue, and then what Dr. Helansky will talk about, and then the next talk's about scoliosis and then contractures. And I say that because I think of fatigue more in terms of inadequate recovery and sleep, and we'll talk some about what happens in sleep that can lead to difficulties. And then I'll talk about some of the thoughts that I have that my colleagues and I go through in terms of chest wall physiology. And I had to interrupt the flow of the title slide by putting a picture of our hospital, which I'm contractually required to do. So I just have to mention some disclosures. None of these have any direct relationship to what I'm talking about, though the final one, Santhera, actually sponsored a lunch that led to some of the hypoventilation criteria that I'll be presenting. But they were not involved in anything further. Okay, so what is hypoventilation? Well, hypoventilation is essentially underventilation due to one of two things. Due to inadequate minute ventilation, so the size of breath, and that's a product of tidal volume and respiratory rate, so how big your breath is, and then how many breaths you give you do in a minute, and then the drive to breathe, which can be impacted based on CNS iatrogenic impact from pharmacotherapies or during acute respiratory difficulties and then more chronically. The outcome of hypoventilation is one or two things. The first being hypercarbia, which is often followed by hypoxemia. And so we can see a combination of those two or just hypercarbia. And when you have hypoventilation at night, and it applies to all of us, if you have a high CO2 or a low oxygen, there are chemoreceptors in the body that will stimulate you to breathe more deeply and cause arousals, so going from deep sleep, where you want to be to get adequate restoration and rest, to less deep sleep or awakening altogether. And those lead to, in all of us, including our neuromuscular patients, less restorative sleep. So I want to set the table by talking about when to look for hypoventilation, and this is general data from the Synergy Duchenne Natural History Study. Though I cited an article that I wrote, I did not collect these data. This was as part of a review article. As lung function declines, just like with any muscle function, I see a series of events happening, and I have them listed over to the right, with increased incidence of respiratory illnesses, and then eventually nocturnal hypoventilation, and then diurnal or daytime hypoventilation, leading to continuous hypoventilation, meaning needing support during the night and day. There are a number of interventions that we can do. The first is doing lung volume recruitment exercises to try and preserve respiratory function, which I'll talk about in the second half of this talk. And then doing daily insufflator-exsufflator therapy to try and mitigate the impact of acute respiratory illnesses. And then evaluating for the presence of hypoventilation. The standard approach is doing a full polysomnogram or sleep study, which requires typically an inpatient stay. And then nighttime ventilation support, and then daytime ventilation support, which can be done using a mouthpiece ventilation. So when we start to look for hypoventilation is when we feel that there's a higher risk. And the general feeling in terms of pulmonary function is that once the vital capacity drops into the 50 to 60% range, the likelihood of hypoventilation rises. And so that's when we typically recommend getting a sleep study. So this is an example of what we get with a sleep study. The top bars represent the stage of sleep. The thick bars represent when you're in REM or rapid eye movement sleep, which is when the muscles rest the most. And so they rest by relaxing. And so that's typically a period where whatever compensation you have for breathing because of your physiology goes away. And that's where you can begin to see pulmonary pulmonary issues at night. The thick bar right in the middle represents capnography. And I have a line drawn roughly at 45 millimeters of mercury, which is the upper edge of normal for CO2. Now, what we do is our sleep medicine colleagues will extract data. The top graph is end-tidal CO2, and it is broken down into different ranges. Those are in terms of millimeters of mercury. As I mentioned briefly, normal is between 35 and 45, but for the purpose of identifying hypoventilation in the general patient population, the general adult population, the threshold is above 50 for 20% of sleep. So you can see here this particular patient, this is one of my Duchenne patients, had a sleep study that had had hypercarbia based on typical guidelines of for only 17.2% of sleep, which would not lead to a diagnosis of hypoventilation. But interestingly, during this time, their SpO2, their pulse oximetry, was completely normal. So there was effectively no time below 90%. So one of the questions that we've asked is, what is the difference between significant and non-significant hypercarbia? And is it in fact reasonable to use 50 millimeters of mercury as a threshold? I would say no, and I'll talk about some of the journey we've gone on since then. The other problem that we have with sleep studies is we typically cancel studies in patients who are sick, meaning we only study them when they're well. And so one of the questions is, well, what happens when you have a child that gets sick, if they're right on the cusp between having normal ventilation and underventilation? The other big issue that we all have is access to doing full polysomnograms. The wait at CHOP, we have a sleep lab with about 25 beds across 3 different sites. The wait is, if you're lucky, about 6 months, typically about 9 months, which makes it virtually useless in terms of doing a rapid assessment, which also means that you have to plan when you're going to get the study. The other thing is that sleep medicine guidelines are typically based on kids with large tonsils looking for obstructive sleep apnea, and then a lot of the capnography data recommendations are based on adults, and so there are some deficiencies. So there are other ways that we can look at hypoventilation. One is, and we effectively just want to look at CO2. There's a end-tidal CO2, which is a catheter that goes in the nose that measures exhaled carbon dioxide. We can also do a probe on the skin called transcutaneous CO2. The problem with inpatient capnography is that whether it's in a sleep lab or in a hospital bed, it's in a hospital bed. It's not in the patient's environment at home. So there is some artifact just based on that in terms of sleep quality. However, we do have the ability to do home studies with transcutaneous CO2 monitors, which gives you the advantage of having the patient in their home environment in a comfortable bed and does not require a 6 to 9 month wait. It can actually be done as frequently as you choose to. This is what we get with home capnography with the monitor download. The top graph represents CO2 in different ranges going from 20 to 30 to 40, 50, and then to 60 millimeters of mercury. And the percentages at the top are the percent time in each of those levels. And so you can see that the peak frequency of CO2 was right around 50 millimeters of mercury, which would tell you that this patient certainly had hypoventilation. And then we can parse things out further down below. I've used a red box to look at where we typically focus, such as the mean CO2, which in this patient was 48 millimeters of mercury, which is clearly above the normal threshold, but is below the 50 millimeter of mercury threshold that is critical in adults. Then you can see over on the right, the bottom right, the percent of time between 45 and 50, and then above 50, which together is about 70% of the total sleep. And that, to me, would be a concern. And with this particular patient, we did initiate non-invasive ventilation. And so we got together a group of interested parties to come up with an alternate approach. And this we did using a Delphi process where we reviewed the medical literature and pulled out criteria for hypoventilation to consider. And then I pulled out, identified 15 pediatric pulmonologists, 10 of whom had formal sleep medicine training to go through this. And we just published guidelines about 2 months ago on some of this work, and identifying what we felt was a more appropriate description of what happens in patients with neuromuscular disease, calling it respiratory insufficiency and neuromuscular disease, or RIND. And so what we did is we better classified what is actually hypoventilation, and then what's normal. And so what we came up with were 3 categories for CO2. One was the percent time above normal, normal being 45 millimeters of mercury. And then the percent time you could have, if you had a very brief but higher period of time with hypercapnia, that also qualified. Then we also looked at a change during sleep. If a patient went into REM sleep and they had a rise of 10 millimeters of mercury in their CO2, we felt that also qualified. And we came up with some other thresholds for SpO2, such as a mean below 94%, and then a time below 90%, which we define as the lower edge of normal for 2% of sleep or 5 minutes continuously. The other thing that we did was we made a category called translational, and this was an idea that one of my colleagues had in saying, well, which patients are normal, but I need to worry about, who might be tipped into the abnormal range during a period of stress, such as an acute illness. And so we came up with patients who had normal CO2, meaning below 45 millimeters of mercury, but with tachypnea, meaning that they're compensating for it. Very similar to, if you remember, taking care of patients with status asthmaticus. If they're tachypnic and they have a high normal CO2, that's a pretty bad sign. And so we wanted to use the same type of idea here. And then looking at thoraco-abdominal asynchrony, so asynchronous or inefficient breathing was another thing that we wanted to see. So what we chose to do from this was using this also as an objective measure. Instead of using started BiPAP as a measure of respiratory insufficiency, go one level above that to defining when the patient actually has respiratory failure or hypoventilation. And this can be used as a clear measure of progression. You can follow the percent time that a patient has a CO2 and whatever threshold you're interested in, and that can give you a better sense of the clinical spectrum and progression, and then allow easier assessment outside of the sleep lab. And what we're actually looking to do now is there are capnographs, transcutaneous CO2 monitors, that can be sent home, similar to sending a patient home with a Holter monitor to look for arrhythmias. And you can download the data. We're actually looking to do that within our electronic health record, and then it gives you a more reliable assessment of how a patient's doing in their home environment. So I want to finish by talking about thoraco-spinal anatomy and physiology to set the table for Dr. Helansky. So as we know, the thorax has a series of 12 ribs, 2 of which are what we call floating and are not directly connected to the sternum through cartilage. And then if you look in the sagittal plane, the spine is not straight, but it's curved. There's a lordosis or a back curve in the lumbar region, and then a kyphosis in the thoracic region. And when our surgeons approach doing corrective surgery or supportive surgery, they try very hard to try and maintain that. To the extent that you don't, that can also alter thoracic and thoracospinal mechanics. This is my Frank Netter picture, which I like to have one of in each of my lectures. This is a great representation of the respiratory muscles. So if you go over on the left, those are inspiratory muscles. The big one is in shadow there, which is, of course, the diaphragm. But then we can also augment inspiration using the external intercostal muscles, so the outside intercostal muscles, which elevate the ribs upward and outward, and the strap muscles of the neck, and the pectoralis muscles can elevate the superior rib cage. And then for exhalation, tidally, exhalation is completely passive, but you can augment exhalation with the internal intercostal muscles, which pull the ribs downward, and inward. And then during a forced exhalation, such as with a cough, you have the rectus abdominis and then the lateral oblique muscles, which compress and increase abdominal pressure to push up on the diaphragm and help with exhalation. If we take everything away and look at rib motion or thoracic motion, to the side the ribs rotate upward and outward in what we call a pump handle effect. And if you look at the coronal plane, the ribs rotate outward and upward, which people describe as a bucket handle effect. And then if we go to the spine, the ribs articulate with the spine. So you have a series of 24 distinct joints, actually 48 because there are 2 for each rib. Joint mechanics apply here just like with any other joint. So if you have decreased motion at the costovertebral joints, you'll eventually get ankylosis and stiffness, which can lead to further difficulty in terms of breathing and a further load on the respiratory system. So I want to finish by talking about the neuromuscular disease and how it impacts the thoraco-spinal unit. So with muscle weakness, loss of function, you get decreased range of motion. That applies to any joint and any muscle. In the respiratory system, that leads to a situation of low compliance, meaning the change in pressure relative to the change in volume. That occurs certainly in the chest wall, where you have decreased range of motion and decreased muscle function. And then when the lungs are kept at a lower lung volume because the chest is not moving out as much as normal, or is in a more contracted state, the lungs at a low lung volume are less compliant. So you have 2 things, the chest wall and the lungs being at low compliance, which adds further to the burden of breathing for a patient with neuromuscular disease. So to dig a little deeper with the chest wall, with decreased thoracic motion, you can get ankylosis of the costovertebral joints, and then eventually, as the muscle becomes less functional and regresses, you can get atrophy, and my orthopedic colleagues would describe doing thoraco-spinal surgery on an SMA patient like going through essentially a sheet of fibrous tissue where the muscle has regressed and has become atrophic and then becomes stiff. That is function that obviously can't be recovered. And then in terms of the lungs, as you go from a normal lung volume to lower lung volume, the airways are narrower or smaller, which adds to airways resistance. And then eventually you get progressive atelectasis, which is further loss of lung volume, which worsens lung compliance and eventually leads to deposition of increased elastic tissue in the structure of the lungs or the interstitium, which adds further to the poor compliance and work of breathing. And this is represented in this, we call it a Ron and Venn diagram, looking at the chest wall compliance in the dotted line over on the left and the lung compliance in the dotted line over on the right. The volume that is the resting lung volume is called functional residual capacity, shortened to FRC, and that's where the outward recoil of the chest and the inward recoil of the lungs are equal and opposite. Now, in neuromuscular disease, if you take a situation where you have less or lower chest wall compliance and eventually lower lung compliance, that volume is at a lower volume. So the resting chest volume is at a lower volume. The resting lung volume is at a lower lung volume, and so your functional residual capacity drops to a lower volume. And again, lower volumes mean less open airways and increased airways resistance. So we have increased burden on breathing because of the tissue itself and then the airways. So I want to finish with a few slides looking at thoracic deformity. So this is a patient with SMA2 in early infancy or toddlerhood, and I would challenge you to find anything abnormal. We don't have much time, so I'll say there isn't anything abnormal. However, in SMA, there's a pathway that typically, without intervention, leads to what you see on the bottom left. This is an SMA2 patient who's about 20, and you can see the downward rotation of the right ribs, the sweeping curve to the spine, and then the collapse of the ribs in the concave side. The picture in Duchenne is slightly different because of less severe deficiency in the thoracic, in the chest wall, and a more sweeping curve with hip instability. And so the final slide I'll just say is that options for altering progression, the further upstream you can go, the better, obviously. And so many of our patients who are getting gene therapies or protein modifying therapies either may not have scoliosis or may have less severe scoliosis. And then clinical interventions, we do some to try and maintain chest wall and lung motion and preserves thoraco-spinal anatomy. And if that all doesn't work, and coincident with that, we engage with our orthopedic surgeons to identify the ideal time to do a surgical intervention. So with that, I will finish and turn things over to Dr. Helansky.
Thank you. It's kind of funny. Hank and I haven't reviewed each other's slides, but this might be the only time you see a pulmonologist talk about bones, and I actually have some pictures of the lungs, so it's kind of crazy. All right. Here are my disclosures, none really related to this talk of significance. So I've adjusted the talk a little bit after some of the discussions yesterday, so hopefully everybody will be on the same playing field as we move forward and understand this. But scoliosis, when we talk about it, is a coronal plane deformity, and really is defined by a curvature greater than 10 degrees. So if it's less than 10 degrees, it's not really scoliosis. The severity and progression is measured by angles, not percent. We get a lot of, I have a 10% curve. No, it's a 10-degree curve. And what often goes unrecognized, except if you've ever been at your PCP's office and they ask you to bend forward and they're looking for this, which is actually not the spine curve, but is actually the thoracic deformity that happens with the ribs when you have scoliosis. So it's a three-dimensional deformity, even though its definition is really in the two-dimension in the coronal plane. You can also have sagittal plane deformities, and we see this commonly with kids with neuromuscular diseases. And these can occur alone or in combination with scoliosis. And as Hank stated, there's a normal thoracic kyphosis, usually between 20 and 40 degrees, and a slightly larger lumbar lordosis. On my last slide, I think, of the whole talk, there's also usually cervical lordosis that's normal too. And scoliosis can be broken up. There's a lot of classification semantics. Some can be by the location of the apex of the curve. Some can be due to the etiology. Obviously, today we're talking about the neuromuscular causes, and also the age at which the scoliosis onset occurs. And kind of the juvenile and infantile have been wrapped up, if you hear EOS or CEOS, as early onset scoliosis, so under the age of 10. Typically, neuromuscular scoliosis is felt to occur due to a loss of trunk support, which leads to the progressive deformity. This can be an uneven support, as some people believe happens with cerebral palsy with uneven spasticity, or we see it with other neuromuscular diseases such as Duchenne's, SMA, and even paralysis. Usually in folks who ambulate and lose the ability to ambulate, the onset of scoliosis occurs with that, and it's more another symptom of the progressive weakness that they have that's not only affecting their lower extremities but also their trunk. It may include pelvic obliquity, shown here with the yellow triangle, and as said before, it often does accompany sagittal deformities. What is common, it's important taking care of kids to realize, is that skeletal growth makes just about every orthopedic pathology worse. So it doesn't matter if you have SMA with low tone, if you are a neurotypical female with adolescent idiopathic scoliosis, or if your child with cerebral palsy. Muscle tone doesn't matter. If you're growing and you have a curve, that curve is going to get worse. Generally, our goals of treatment are to prevent progression. Every person that comes in, every patient that comes in thinks our primary goal is to straighten their spine out. Our primary goal is to keep their spine from getting worse. how straight we can get them is related to a lot of different things, but it's primarily to prevent progression, and usually trying to do that in a balanced fashion to keep somebody's head over their bum, and to try to minimize cardiopulmonary complications. And in neurotypical kids, usually the thing that we quote is about 60 degrees is when you can start to detect changes in their PFTs. But really, clinical differences aren't usually seen till up to almost 90 degrees. And again, this is in normal children, not in any of the neuromuscular kids. For the non-ambulator, we're also trying to balance their seating posture to give them a level surface to sit on, as well as what often goes missing is freeing the upper extremities for other activities so they don't have to keep bracing themselves or repositioning themselves in their seat. Kyphosis is interesting in that it does appear when it's by itself. Usually have less effect on pulmonary function than scoliosis, and this is in both adults. There's a Framingham study as well as in children. I added this slide or expanded it after the brace discussion yesterday. These are probably two of the best studies, for sure. The one by Stu Weinstein, it's in the New England Journal, on bracing, and these are in adolescent idiopathic kids. There's no data like this in any neuromuscular condition. This shows that basically a dose effect with bracing, and if you're not wearing your brace for up to 13 hours a day or more, you're likely not getting a big effect. So that's in neurotypical kids. So if you add in the abnormal neurology, it probably needs to be even more than that in the children with neuromuscular conditions. Usually we're using bracing to help with seating balance. So for a functional reason, and it's very important to explain that to the parents, that's why we're doing it. We're not doing it to stop this curve. We say it may slow it down, but there's very little data to actually demonstrate that. And I know it came up yesterday that the compliance is never what we say it is. There are things you can have your orthotist do, and both of these studies were very good in that there were some of the first studies that included these temperature sensors or data loggers that actually can track what the brace wear is, and they can be added to most orthotics. And I know it came up yesterday, the idea of rods or growing rods, and the families say all different things, so I figured I would try to explain the difference. So we do have growth-friendly surgery. Some of them are listed there. These are typically what we call the growing rods. I'll show the magic rods later. Those are something that are just basically a fancy growing rod. But essentially, we limit the area that we fuse to the areas where we actually fix the rods to the spine, and either mechanically, manually, through repetitive surgery, go in every 6 months, every year, and lengthen those rods to increase the thoracic or overall spinal length. The magic rods do that non-invasively, which is why we've kind of gone to that direction. Or a spinal fusion, which essentially the reason it's called a fusion is we are trying to get every vertebral level to fuse to its adjacent level throughout the whole system that we instrument. And so you can see it's quite an invasive surgery. You can see, and even though we do shared decision making and try to inform consent, sometimes on the day of surgery, families go, wait, are they going to be able to move through that? You're like, no, there's steel or titanium that's holding their spine together. They're not going to grow. They're not going to have any motion through the areas that we fix. The benefit of fusion is usually that's considered a one-time surgery, whereas often the growing rods need repetitive surgeries, and we'll talk about the incidence, which is really, or the indications, which is really age-based reasoning for the difference. So looking at Duchenne's, the natural history, I think most people here know, most of the kids will develop scoliosis if they're not treated medically. And as shown on the last one of the last slides of Hank's, usually these are big, long, sweeping thoracolumbar curves. Typically, the chest wall is not as involved as it is in SMA. Kyphosis is common, and bracing has not really worked well in this population for numerous reasons. When to operate, really a lot of our orthopedic literature is based on their pulmonary function, is getting to these kids before they start to see a big decline in their pulmonary function. I will say some of that's historic. With good pulmonary care and good respiratory care, usually you don't have to be quite as aggressive, and some of the kids stay in a 30 to 40 degree curve that may not ever need surgery. These kids, these are probably some of the hardest surgeries we do due to the very thick tissue and woody tissue that Hank was describing for the SMA kids too. Their muscles are not normal. They do bleed a lot. It's probably the highest EBLs that we see in orthopedics. It's usually 3 to 4 liters have been quoted in the literature. So they're big cases when we do them. This is a little bit, I don't know if there's any other orthopedic surgeons here, but this is usually we fuse long. One of the questions, also in SMA is, do you fuse to the pelvis or not? In Duchenne's, usually if there's less than 10 degrees of pelvic obliquity, you can stop at L5. Outcomes, it does improve seating balance and comfort. This has been shown in a lot of studies. It may not improve or prolong pulmonary function. The data is very sketchy on that. There's a pretty high complication rate, and it has to do to the cardiac pulmonary, infection risk and blood loss. This is one of the things that I've noticed and learned over time taking care of these kids. One of the things that some of the families kids get pretty disappointed about after spinal fusion is they're used to bringing their head down to their hands, and once you fuse them up, a lot of those independent activities are no longer independent. So it's really important to talk to the family and the child before the surgery to let them know this may occur for those that have weak upper extremities. Obviously, this need has been drastically reduced in the era of steroid therapies. There's multiple studies to show the dramatic reduction in need for scoliosis surgery. And, some of the potential things that were brought up yesterday, will this change with weekend intermittent therapy? Will we see scoliosis come back with some of the gene therapies? Is that with more normal skeletal growth? Will we see that? I think those questions are largely unknown right now. Switching gears to the SMA, obviously in pre-disease modifying therapies, spine deformity and SMA 1 and 2 are very common. In one of our papers that looked at really hip pain in these children, we had 70 out of 72 children had type 1 and type 2 had scoliosis when we reviewed their charts, and at that their mean age was 7 years old when they were diagnosed. It is important. We've looked at this. It's important to the families. It's important to the caregivers. How do we treat their spinal deformity? And as shown, this is the classic parasol shape or bell-shaped chest wall that these kids get. And Hank went through kind of the pathophysiology on this. And what's interesting is when you could combine that chest wall deformity with a spinal deformity with that curve, you get these crazy thorax shapes where everything is not where it should be, and almost obliteration of the lung field. And don't pay any attention to the pedicle screw tickling the aorta on the one picture there. That's just a normal child that had needed their screw removed. But you can see in this 3D CT of really what those ribs do. They kind of fall down on themselves and shingle on that side, and it does create almost a rigid, sharp bone there where that occurs. Bracing for children in SMA, again, usually functional and seating improvement is why we use it. Sometimes you can have them actually trial it to know what it's like if we do spine surgery. Typical challenges are you have these weak bones, which we'll hear about next. You have this chest wall deformity, and the way the brace works is to push on those weak ribs to try gaining correction of a stiff spine. And so you're probably more likely to actually cause more chest wall deformity than you are to correct the scoliosis very much. We've found, others I know have too, that semi-rigid TLSOs work better. That's almost like taking the inside out of a normal plastic TLSO, and it's a little bit more rigid styrofoam. And doing an abdominal relief is very important. Obviously, these kids often are diaphragmatic breathers, and giving them that abdominal excursion is important. Oh, okay, showing that, and then pushing. Okay, what do we know from the literature? A lot of this are older studies, but the adolescents with spinal muscular atrophy do appear to do better, benefit from spinal fusion, improved seating balance. We have good curve correction. There's still, just as it is in the Duchenne's, questionable slowing of the pulmonary compromise, or pulmonary functional losses, but we do see some function that is more difficult for these kids after their surgery. But unlike Duchenne's, we tend to see the curves and some severe curves quite early. And looking at this, you know, why don't we fuse the 4-year-old? Why is that not typically what we do? And this gets into the lung development and lung growth. There's lung branching that continues up to 8 years of age, and then increase in that alveolar size that happens. And if we fuse somebody when they're young, we can, you know, lose quite a bit of lung volume. So typically, we don't want to fuse them at 4 years of age, because you can see, you know, the amount of lung volume they should be gaining throughout adolescence. So that's why we've kind of come up with these growing rod techniques. And we and others have shown using a distraction-based growing rods in SMA is a very good way to help preserve growth, or at least allow thoracic growth to occur. These are the magic rods. If you hear patients talk about them, everything is the same except the way they distract. Because there are magnets inside, you can usually get them to lengthen through the skin versus having to do this manually. There have been some issues with these rods, had different recalls or warnings and different things. In the SMA population, I can say they have worked very well. And I have some of it down there, but the maximal expansion you can do, the bigger, there's 2 sets. The bigger one you can do, which is hard to get into a small child, is still only really 2 inches. So I don't know the physiology and how important 2 inches of thoracic height, or actually total spinal height, is to the respiratory effort. But you just have to kind of keep that in mind of, you know, is it worth the bang for the buck? Folks have looked at these types of devices, which is called the Vector or rib devices. The thought was if we could hold those ribs up, we could prevent that parasol deformity. There's been 2 studies that have shown it doesn't really work to do that. These are still options. One of the problems that we've seen with these devices is that you have these weak bones that you're pushing on these ribs, and you do see a lot of migration of those hooks that can occur. We'll go here. You know, are they worth it? This was one of our other studies looking at growing rods. And again, I question this looking at it. You know, we did, these kids averaged, I think, 5 surgeries, and really we gained them 3.5 centimeters of thoracic height. You know, these were some of their PFTs over time. I don't know if it was really worth all the effort, or if they would have been done better if we would have waited and done a fusion. So current indications, less than 8. Usually we're looking at, with a curve that's progressive, one of these posterior distraction growing rod techniques. Over 10 years of age, usually a spinal fusion. And in between that, it's really a discussion. This was just a cross-sectional study that we did. We did find kids that, and the spine was not the goal of this study, but it was looking at some patient reported outcome measures. But we did find they did do better and score better in a lot of different areas, which was encouraging. This is a hot topic. I'm glad wasn't the focus of my talk today, but we have seen that instrumentation to the pelvis does appear to increase the risk for having hip pain. And folks in Hopkins have also shown that spinal fusion does appear to exacerbate hip pain seen in these patients. And this is just something I would call for folks to see, because you're going to see a lot more of these kids as they get older. And get back to Hank's for one of his first comments of that sagittal balance and how hard how tricky it can be. We've noticed, and I'm sure taking care of these kids, you've seen two kids like the ones on the bottom there that either sit so forward in their wheelchair they can't get back to their backrest, or that really have that retracted jaw. And often those kids do have a bit of progressive sagittal balance in their spine that's going on. And we reported a case report on one child who was losing upper extremity function, and really he had cervical myelopathy due to this progressive cervical kyphosis that he had after years of having growing rods in place. So, you know, big question, have the DMTs eliminated spinal deformities, you know, in SMA like they have in Duchenne's? And simple answer is no. There's been several studies that have come out that show there's just as much, if not more, spinal deformity in the kids that are on nusinersen or that have gene therapy. And this kyphoscoliosis, especially in the really young patients, is going to be a big problem. And, you know, should we be looking at prophylactic bracing or augmenting, you know, what we're doing in therapy when they're very young? I don't think we know. So spinal deformity in kids with neuromuscular conditions is challenging. The recent medical advances have really helped in the DMD population, not helped in the SMA population, at least as of yet. And you know, orthopedic correction does not make them normal. I think that's kind of a common theme we've heard throughout yesterday and today. And so I think a lot of folks are going to start to see a lot more kids with spinal muscular atrophy and bad curves. Thank you.
Okay, thank you so much. Any questions from the audience? If not, I'm going to get started with one from, oh, there's one, sorry. Go ahead.
Anyway, with the gene therapy now and maybe expecting more kids with type 1 and type 2 to be either independent or assisted walkers, do we think every kid with type 1 will still get scoliosis? Or is it more related to walking than the actual typing?
You know, looking at what's been reported, it looks like a large number of them will, probably not all of them. I do think it'll be probably functionally related, that the kids that, but I know that hasn't been completely true talking with folks, that there are kids that are walking that have horrible scoliosis. But I do think it'll probably be less. I think that won't be totally the way that they'll all be.
And for non-walkers, is there any evidence that use of stander helps prevent the scoliosis or decrease it?
I've not seen any evidence of that, no.
Oh, go ahead.
Hi, that was a great talk, both of you. Do you have any general recommendations on patients who are having progressive or notable kyphosis, maybe other than a head brace to their chair?
Yeah, no would be the easy answer. I do think on a lot of these younger kids now that we're seeing that we have to do some type of bracing. So there in adolescence there is Schurman's kyphosis. That is something that we see in relatively normal kids. And bracing at a younger age while they're growing does appear to be effective at controlling it. So I do think that makes sense, some type of bracing when the kids are young. What does that look like? You know, there's different thoracolumbar orthoses, you know, something that's pushing up pretty high in the chest. Will it be tolerated? Will that cause other problems with the chest wall? I don't know, but I do think we probably will start doing that prophylactically on some of the kids.
Okay, so I have a few questions from the online audience. SMA children on disease-modifying treatments are now sitting, which seems to cause earlier kyphosis with or without scoliosis? Are there any different surgical or non-surgical approaches specific to kyphosis, or are they the same as for scoliosis?
So, two things. One, I think, as I said, I do think probably these children, if we're seeing that, need some type of orthosis to help prevent it from getting worse. The problem with kyphosis is usually we're less aggressive about it than scoliosis. And part of the reason is if you try to fix someone's kyphosis, it's very difficult to stop it from happening above. So you have a lot of junctional problems. So if you're doing that on a growing child, this is going to be something that you'll probably be chasing up to the head, to be honest, of fusing up to the head. Because if you try to stop in the thorax, they're probably going to get that in the neck. Then you're going to have to fuse to the neck. It's just going to be a little bit of a disaster, especially when we're seeing this on the kids that are 2 or 3. So usually, orthopedic-wise, we try to hold off if we can.
Okay, thank you, because that is a very common.
I would also say I do think probably, and I know different centers are more aggressive about this than we are, I do think things like halo traction before surgery is probably going to become more common. That's a way that we can correct some of that kyphosis before surgery, because the other problem with kyphosis surgery is there's a lot more risk for neurologic injury during surgery. So doing this gradually with having these kids in halo traction, which you all can imagine how fun that'll be with kids with SMA, is probably going to be more common.
At surgery, is paraspinous muscle fibrosis in DMD and SMA fairly uniform from caudal to rostral regions, or is there any tendency for muscles at certain levels to typically be more involved?
My experience has been they're all fibrotic. In my experience, has been more in the Duchenne's than in the SMA, that they're very woody.
And then the last questions for orthopedics. With decreased chest wall mobility and respiratory weakness, would treatment for rib and spine mobility be indicated for patients with DMD? And would the use of TLSO for scoliosis management for as many hours as it's generally recommended contribute to chest wall mobility and respiration?
So
I can repeat the first one. It's a little bit confusing. With the decreased chest wall mobility and respiratory weakness, would treatment for rib and spine mobility be indicated for patients with DMD?
Well, I think yeah, and I was going to say I think DMD is a little less chest wall deformity as well. But yeah, feel free.
There are some data to suggest that if you do deep breathing exercises, range of motion, hyperinflation, lung volume recruitment, expanding the lungs and the chest up to full capacity, that can potentially decrease loss of compliance, loss of lung volume. It's far from being a proven therapy, but I think it has potential.
Okay. For Hank, do BiPAP or cough assist improve lung compliance, chest wall compliance, or both?
Depends on who you ask, actually. Matt's colleague, Mary Schroth, who's done a lot in SMA, absolutely insisted that using non-invasive ventilation early can prevent chest wall deformity. I don't know that I have a hard time believing that completely. I think it can contribute to it. The sooner you have a patient doing regular breaths, but these are tidal volume breaths, which are the sort of resting lung volume. And I think to really do range of motion and maintain mobility, I think we need to do expansion beyond sort of the normal range of motion. So I think it can be helpful. I'm not suggesting that's not helpful. I just don't know that it's I don't know that it can be the only intervention. I think we probably need more.
Understood. And the last question, with home sleep study using transcutaneous capnography and oximetry, can you differentiate between obstructive sleep apnea, non-obstructive sleep hypoventilation due to inspiratory weakness, on central hypoventilation due to impaired drive?
Well, you cannot diagnose obstructive sleep apnea on just capnography, but there are home sleep studies that allow you to do that with some other signals. One of the things that's a bit challenging in neuromuscular disease is that you can, especially in Duchenne patients who can, in addition to upper airway muscle weakness, may, because of steroid side effects, carry some extra weight, are at risk of having obstructive sleep apnea. But the time where obstructive sleep apnea treatment with CPAP would be appropriate is limited, because they all will eventually get to the point where they actually need inspiratory assistance, so needing bilevel pressure. And so it's always a little difficult to identify that very brief period of time.